Hi, good morning everyone. Today we'll be seeing some radiology cases in pulmonary medicine. So there will be four cases we'll be discussing today. The first case, it was basically a 69-year-old male who came with chronic cough. Let's see the mediastinal and lung window in this patient. Here we were able to see that there was tracheal and bronchial wall thickening. You can see the tracheal and bronchial wall thickening which is showed in the arrows. And in lung window, we were able to see that there was fibrobronchiectatic collapse of the right upper lobe. So I'm just showing three spot images of the images that we had seen earlier. So here we are able to see that there is bronchial wall thickening involving the left main bronchus. Is extending superiorly till the level of the lower carina, which is seen here. It's also seen in the middle aspect of the left lower bronchus, left bronchus. Also the right brain bronchus is also thickened. So this is a sagittal view in which we are able to see the anterior part of the trachea is also thickened and the posterior wall of the trachea is also thickened. So coming to the differential diagnosis for tracheal and bronchial wall thickening, there are two important radiographic features. One is whether there is posterior membrane which is involved. Second thing is whether there is calcification that is present within the wall thickening. So based on that, there is an algorithm in which we see if the posterior membrane is fat, then it is most probably a cartilaginous etiology, because we know that the posterior part of the tracheal cartilages are deficient posteriorly. There's only cartilage which is seen in the anterior aspect. The posterior part of the trachea is not having any cartilage. So if the posterior part of the cartilage is not involved, then it is a cartilaginous etiology in which either it can be tracheobronchopathica osteochondroplastica, or it can be relapsing polychondritis, depending upon whether calcification is present or absent. Relapsing polychondritis can present as with calcification or without calcification. And this, and if the posterior membrane is involved, then again it is again divided further into calcification present or absent. Depending on that, it can be either amyloidosis, sarcoidosis, or it can be Wegener's granulomatosis, IBD, and amyloidosis. So coming to our patient, so we saw tracheal wall thickening, bronchial wall thickening. The posterior membrane is definitely involved here. There is calcification which is absent. So the possibility in this patient would be either granulomatosis with polyangiitis, IBD, or amyloidosis, which was raised in this patient. Coming to how these patients will look in CT, tracheobronchopathica osteochondroplastica will show nodular calcification, which is seen in the anterior part of the trachea. The posterior membrane is uninvolved. Relapsing polychondritis will have, again, typically posterior membrane is uninvolved. Either it can present with calcification or it will not present with calcification. Then the two most important causes, tuberculosis and malignancy. We see a tracheal mass which is seen in the right upper trachea. It's extending and involving the left side of the trachea also. Tuberculosis is another common cause which we see as a important differential diagnosis for tracheal wall thickening. The other things are infection, granulomatosis, polyangiitis, amyloidosis, and post-radiotherapy. Yeah, subglottic stenosis and tracheal stenosis in an ICU patient who had undergone intubation, post-radiation as well as post-intubation stenosis are two important things that we have to consider. So a biopsy was done from this tracheal wall thickening in which we saw amorphous homogeneous eosinophilic deposits. Congo red stain was given because the possibility of amyloidosis was raised. So in that we were able to see this typical apple green birefringent fibrils which are seen under polarizing light. IHC also showed that this patient had elevated levels of serum amyloid associated protein. So the diagnosis of amyloidosis was considered in this patient based on radiological diagnosis of wall thickening and a confirmation of biopsy of amyloidosis. Coming to what exactly is tracheobronchial amyloidosis, let's just see a small overview. The native protein, instead of getting properly folded, if it gets misfolded, then it gets deposited at fibrils, which are beta pleated in nature. Instead of being folded like this, it gets beta pleated like this. and these gets deposited as amorphous protein. Can be of two types, the primary or secondary type. Secondary type is more common because it's commonly associated with chronic inflammation, which is nearly commonly present in many of the patients that we see, which raises interleukins 1 and 6 and causes the deposition of serum amyloid associated protein, which was what was seen in our patient, which shows a AA protein. Apart from that, there can be a primary amyloidosis in which you see AL protein deposition, or senile or hereditary type in which there's production of normal amount of mutant proteins. These are normal proteins which are folded in an abnormal manner. There's abnormal amounts of mutant protein which is C, which is mutant transthyretin, which gets deposited as ATTR protein. So the take-home case about the first patient is amyloidosis is an important cause of tracheal wall thickening. So this was a case of a tracheobronchial amyloidosis, and it is an important cause of tracheal wall thickening that we need to consider. And this is important because unless you raise this, we saw that congruent stain was given in this patient. Unless this particular thing is raised by the radiologist, the pathologist might not think about doing special stains. In an H&E stain, it will just look like pink and purple colors. So unless you specifically raise amyloidosis, the necessary further evaluation will not be done clinically as well as by the pathologist. So always remember this. But that doesn't mean for every other case that we are going to see from today onwards, we are going to label it as tracheobronchial amyloidosis. The two most important causes are going to be obviously tuberculosis and malignancy. And if it is not going to be TB and malignancy clinically, then we are going to raise the possibility of amyloidosis or granulomatosis with polyangiitis. In fact, in this particular patient, actually, when the bronchoscopy was done, the pulmonologist called me and told that, sir, I once I take the biopsy, it keeps occurring. How much amount of necrotic material I'm taking from the bronchus keeps recurring actually. So this was atypical for tuberculosis and malignancy clinically, and hence the review was asked for other differential diagnosis. These patients also present with non-caseating necrotic lesions. So coming to the approach, the algorithm we saw, it involves posterior membrane involvement and presence or absence of calcification. So it's a quite rare kind of a thing. Less than 100 cases are reported in literature, and the prognosis, it is a progressive course. It keeps on occurring, and the treatment is you have to keep on debriding it, and either by bronchoscopy or by laser, but you cannot prevent progressive airway narrowing. In fact, our patient, we saw a fibrobronchial collapse which was seen in the right upper lobe, which could be because of airway narrowing and stenosis which has occurred secondary to the wall thickening which we saw in the tracheobronchial amyloidosis. So that is case one for us. The second patient was a 25-year-old lady who came with cough. So let's see. So this is a CT chest, multiple cavitating nodules we are able to see, showing the cavity within the right upper lobe nodule. So it has a central peripheral distribution, soft tissue kind of an appearance. Let's see the mediastinal window. There is mild enhancement which is seen within the mediastinal lymph nodes. There is no mild enhancement of the cavities, no mediastinal lymphadenopathy and pleural effusion. So I'm just putting up the radiograph to just show us how these cavitating nodules look in a radiograph. Here we are able to see this is a normal soft tissue nodule, which is the CT correlation which is shown here. This is the same nodule. When it shows cavity, which was seen in the anti-segment of the right upper lobe, we are able to see that there is a cavitation component which is seen. So whenever you see cavitating nodules, go back and review a radiograph to see how they look in chest X-rays, because it's very difficult to pick up subtle sets of cavitation. So the best way to learn radiograph is to look at the CT and come back and look at the radiograph. So it makes much more sense to us. So here the differential diagnosis, the most important thing that we were trying to work out with is the cause of cavitating nodule. Early case it was cause of tracheal wall and bronchial wall thickening. Now in this patient it was more of what is the differential diagnosis for a cavitating nodule. So there's a huge list. Infections, necrotizing, acute or subacute, depending on it, necrotizing infections, septic emboli, bacteria, fungi, and rare organisms like parasites. Malignancies in which a primary malignancy or a secondaries from solid or organs or from lymphoma, Kaposi sarcoma, autoimmune causes and other causes. So, how do we remember this for PG students? We remember it by the cavity. What is the difference for cavity? Is going to be cavity, which is cancer, autoimmune, vascular, infection, trauma, and youth. So in the exam, please start discussing your differential diagnosis from infection, which is more common when compared to cancer. So which is what we'll be doing right now. So this is the first important cause of cavity, that is infection. We will like to remember six infections in our day-to-day practices. One is abscess and tuberculosis. Both of them are going to have thick enhancing walls with airflow levels. And maybe tuberculosis will have a slightly thinner wall when compared to tuberculosis. The next two set of infections are going to be fungal infections, where there's a fungal ball. Here we are able to see an air crescent sign, which is seen in the non-dependent part of the cavity, with the fungal ball in the myostome and the dependent part of the cavity. Then there is the chronic necrotizing or semi-invasive aspergillosis, in which there's a soft tissue speculated. Sometimes it can look like a speculated soft tissue mass, which surrounding ground glass opacities. Then there are two other infections, namely septic emboli, which can be random in distribution, cavitating, and variable size, and non-tuberculous mycobacteria, in which again soft tissue nodules as well as cavitation. So abscess and TB, fungal ball and chronic necrotizing aspergillosis, two fungal infections, and two infections, namely septic emboli and non-tubercular mycobacteria, which have typical etiology: IV drug users, middle-aged ladies, lady with Windermere syndrome. Okay, so these are the six infections that we are going to remember for cavitating lung infection. Next is autoimmune. In autoimmune, it is going to be two important autoimmune conditions, namely Wegener's granulomatosis and rheumatoid nodules. Um, to differentiate between these two, let's see the images first. So yeah, there will be a soft tissue nodule which can show cavity, and the good thing about autoimmune is with adequate treatment, it completely dissolves, or at least the soft tissue will become the soft tissue component of the lesion totally dissolves, and there will be only a small bulla or cyst which will be residual over a period of time. So this shows excellent response to treatment. So they will be of so in rheumatoid nodules, the cavities and nodules will be more peripheral in nature. We can see it's more peripheral, whereas in Wegener's granulomatous is more central perihilar in location. As far as rheumatoid arthritis, rheumatoid nodules is common. Rheumatoid arthritis is more common, but only 1% of rheumatoid arthritis go on to develop rheumatoid nodules. This we need to remember because it's quite rare in even in rheumatoid arthritis patients. But however, patients who have pulmonary findings, 20% of patients have these findings. They occasionally cavitate. Whereas in Wegener's granulomatous, nearly 70% of the patients will have these cavitating nodules, and 50% of them will show cavity, and remaining will not show cavity. Coming to the third important causes, we saw infection, we saw autoimmune, now we are moving on to cancer. The hallmark of cancer is they will be of different size, predominantly involving the lower lobes, because more amount of blood supply goes there. They are usually of different size, indicating that they are embolized at different times, indicating different times of tumor embolization. So the growth will be different in the different nodules. Coming to the causes, primary, it is going to be squamous cell carcinoma. Secondaries, it can either be cavitating or cystic cavities, cystic metastasis. Cavitating basically means a thicker wall. Cystic basically means a thinner wall. We need to remember a couple of causes for the cavitating thing. So above the level of clavicle, it is squamous cell carcinoma of head and neck. Below the level of clavicle, it is adenocarcinoma of the breast and GIT. Apart from that, transitional cell carcinoma, cervical carcinoma, and pancreatic adenocarcinoma. These are like 4 or 5 important causes of cavitating lung metastasis. Cystic metastasis, the most important thing that is usually asked in exam is osteosarcoma, in which there will be a cystic nodule which ruptures and the patient presents with pneumothorax. But a more common thing that we see in day-to-day practice is going to be a colorectal malignancy, endometrial cancer, urothelial cancer, and epithelioid cancers. Coming to the other causes like VITY, vascular trauma and UTI, infections we already saw. Vascular is going to be a pulmonary infarct, but the clue is going to be in the pulmonary embolism. So pulmonary embolism, you see a wedge-shaped OPC, it's going to be a pulmonary infarct. Trauma, laceration, the history is going to be very typical. There's going to be a history of trauma, there's going to be a fracture, and there's going to be a laceration, consolidation, contusion, and laceration, which would be seen. If it's more thin wall, then it's going to be a pneumatocyst. Pneumatocysts can also be seen in infections. And the last one is going to be in pediatric age group, youth. So congenital pulmonary adenomatoid malformation, CCAM or CPAM, which also presents as a cavitating or more of a cystic lucency, which is seen. Then there is bronchogenic cyst. So bronchogenic cyst can be fully fluid or it can be ruptured, and in which we will be able to see the air within which is seen within the cyst. So this is a very good approach which has been given by Gafoor regarding. So we saw all these reasons of cavity in day-to-day clinical practice. When you are meeting a cavity, how to proceed. That is what has been told by Gafoor. First and most important thing is, are we dealing with true cavities? So in case if you are going to make something as cavity, make sure that you have ruled out these three important things which are more common, namely cysts, emphysema, paraseptal emphysema especially, bulla, and also I'll like to add honeycombing of the ILD. So that can also present as a cavity. So these three or four things needs to be ruled out first before going into the approach for true cavities. Second important thing is it less than 3 months old or it is more than 3 months old? So if it's less than 3 months old, it's going to be more probably an acute infection or maybe subacute infection. Maybe pulmonary embolism is another thing that can be added to this list. And if it is more than 3 months old, it is either malignancy or it is autoimmune. And there might be a few chronic infections, namely tuberculosis, fungal, and atypical organisms. Third step is clinical history. For example, uh, again, clinical history might be non-specific. As you can see, even in autoimmune, it can typically present with fever, in which case it can confuse with an infected etiology. Malignancies, there will be weight loss, hemoptysis, fatigue, chronic infection. Again, chronic infection and the malignancy again will have the same kind of a clinical history. So clinical history, if it is like specific, for example, if there is an IV drug uses, yeah, septic emboli, pulmonary embolism, acute onset. So some clinical history will help us in narrowing the differential diagnosis. Then the last step is going to be, is there any specific imaging findings? Like, for example, in septic emboli, it's going to be variable sized cavities and nodules, IV drug uses. Sometimes you will see an aneurysm. In case of rheumatoid arthritis or Wegener's granulomatosis, is going to be a waxing and waning kind of an appearance where these nodules will resolve. Cancers, it's going to be thick walls more than 15 mm or thickness, but 15 mm cutoff is for radiographs, not for CT. In CT, I think it's going to be 8 to 10 mm. Infections, yeah, there's going to be severely sick patients in ICU for necrotizing pneumonia and septic emboli. And fungal infection, it's going to be a 3 month history of duration of an infection. So these are the four important questions that we are going to look in any cavitating lung disease. So what did it turn out in our patient? Turned out to be Wegener's granulomatosis. So Wegener's granulomatosis, now we started calling it as granulomatosis polyangiitis. Fine way of brushing things under the rug. So what we need to know about granulomatosis polyangiitis is it is a triad. So there is going to be systemic vasculitis, there is upper and lower airway granulomatous inflammation, and there is glomerular nephritis. So if you see these three things put together, where the kidneys, lungs, and the upper airways are involved, then it is going to be called as a triad of Wegener's granulomatosis. Patients will present with fever, weight loss, hemoptysis, hematuria. So it will be a findings of both infection as well as malignancy. But the hallmark is going to be hemoptysis, hematuria, and saddle nose deformity. See these three things, your top differential diagnosis is going to be Wegener's granulomatosis. So what do we look for in this patient for diagnosis? We look for C-ANCA proteins. So that is the cytoplasmic anti-neutrophil antibodies. It does very well with steroids and cytotoxic agents. And the differential diagnosis is going to be Goodpasture syndrome and Chest syndrome, because clinically hemoptysis would be these two important differentials. So this was a thing where we are able to see neutrophilic infiltrates. The biopsy was correlating of Wegener's granulomatosis. Take home message from the second cases. So we need to remember autoimmune cavitating nodules as another important differential. Apart from infections and malignancies with primary and secondaries, the third important cause of cavitating nodules are going to be autoimmune, out of which Wegener's granulomatosis is the most important thing, or granulomatosis with polyangiitis as it's called nowadays. Remember the triad of Wegener's, where we see necrotizing granulomatous inflammation of the upper and lower respiratory tract, which can present with hemoptysis clinically. Systemic or focal necrotizing vasculitis involving the arteries and veins, and because of this vasculitis, there will be cartilaginous dissection and saddle neck nose deformity. So actually, this is the granulomatous. The other couple of cases in which I've seen it has turned out to be Wegener's granulomatous were actually diagnosed to be tuberculosis. We thought it was granuloma. It turned out to be tuberculosis, but gene expert was negative. Further investigations, you try everything, nothing is working out. Then when you review everything, you find out that these granulomatous are going to be granulomatous with polyangiitis. These are not granulomas of tuberculosis. So once you see a patient with saddle nose deformity, you'll remember it for the rest of the life. We had a patient like that also, in which the complete nose got detached. It started with a small infection. We thought it was a small infection. There was debridement which was done outside. Repeated debridements were done. Then finally, by the time like the tip of the nose was completely gone, we were able to make it that this is going to be a Wegener's granulomatosis. So again, granulomatosis is another thing that the radiologist has to keep in mind. And once you raise this possibility, it's going to be evaluated further. In kidney biopsy, we are going to see focal segmental necrotizing crescentic granulomatosis, which is hematuria. So surgical procedure is not indicated because the more the trauma you're going to give, the more the pathology is going to get excited and it's going to increase in the size and morphology. So surgical procedures are usually withheld in case of Wegener's granulomatosis. So in exam, whenever you see a sinusitis and cavitating nodules, it's going to be Wegener's granulomatosis until proved otherwise. But in day-to-day clinical practice, how much importance to give to the sinusitis is going to be very, very skeptical, very whimsical also. This is in fact the penis X-ray of this patient who had a left side sinusitis. So yeah, sinusitis is also present in case of Wegener's granulomatosis. Coming to the third patient, this was a 54-year-old patient who presented with cough. Let's see the images. So we are able to see calcified cyst in the liver and simple cyst in the simple cyst with fat in the segment 6 of liver, 7 maybe. And mediastinal window, we are able to see that there's an air fluid level cyst or cavity or abscess which is seen. So I've just summarized the images here. So there is a lung cyst with air fluid level which is seen here. Then there's a fat containing hepatic cyst. See, can we see the fat which is seen in the superiormost part of the cyst? So there's a fat containing hepatic cyst. And there's a calcified hepatic cyst which is present here, and there is a cyst which is seen in the spleen. So these are the images in which we have. So the single unifying thing in which we are able to see, for example, the calcified cyst for all practical purposes is going to be hydatid. And there is a air fluid level, which means it could be a case of a hydrocyst which has ruptured. So unifying diagnosis for all these things was possibility of hydrocyst, but I was more interested in why the cyst was showing fat contained in it. So I called this patient for an ultrasound. This was a cyst in which there was fat. When we did an ultrasound correlation, you can see the beautiful membranes which are seen within the so-called simple cyst with fat levels in it. So once you see a membranes, it's very clear. If you see membranes like this, it's going to be hydrolysis for all practical purposes. We had a comparison radiograph from 2022 in which there was no cyst in this patient. So the presence of membranes raised the possibility that it was a multi-system hydrolysis, and this patient came basically presented with cough. It was a pulmonary hydrolysis for which he was seeking a treatment from us. So here what we are able to see is we need to remember the pulmonary findings. So I have just listed out these findings which has been taken from this article. So either it can be uncomplicated, in which it will just look like a smooth cyst with daughter cyst and calcification. It is complicated when it gets either rupture or it gets infected. So if it is ruptured, it can be a complete rupture or contained rupture, depending upon whether the pericyst and endocyst is involved or only the pericyst is involved. Let's see what exactly this is later in the images. Based on that, there are 3 signs here, 6 signs here. We'll review all those signs later. Associated findings could be any of the collapse-related findings. So this contained rupture where the cyst is ruptured only into the ectocyst. So here we are able to see an crescent sign which is seen in the more superficial or non-dependent part of the cavity. Inverse crescent sign is if it is going to dependent part of the cavity. If it is dissecting through the posterior part and in the lateral part of the membrane, it's called as inverse crescent sign. Air bubble sign is when it is in the center. So basically it means it can be in the superior, it can be in the inferior, or it can be in the central. In which case it is called crescent sign, inverse crescent sign, and air bubble sign, which is seen in contained rupture. Complete rupture is when it has totally ruptured, in which again we can see these 6 signs. So if the ectocyst and endocyst both are ruptured, we'll see double arch. There's one arch with the endocyst, the other arch is with the ectocyst. So there will be double arch sign, which is also called as the onion peel sign or combo sign, but double arch explains the etiology better. So let's stick to that. And depending upon the degrees of rupture, either it can present as a mass which is seen within the cavity, or it can present as a membranes which is seen within the cavity, which is called whorl sign or serpent sign, or there can be still fluid as well as membranes, in which it is called as water lily sign or camlet sign, or it can have a rising sun kind of an appearance. So these 4 signs are basically the means different levels of evacuation of fluid which is seen within the cavity. The last one is going to be empty cyst sign, in which there's going to be completely a simple cavity, in which case it becomes very difficult for us to raise the possibility of Hydatid cyst. So these are the 6 findings of complete rupture. So why exactly we see this meniscus sinus? This is pink, pink or some color. So there is air which is seen within the pericyst. If it is only in the pericyst, it's going to be called meniscus sign. If it is within the pericyst as well as the endocyst and ectocyst, it's going to be called as a Kimbo sign, or more easier to remember is the double arch sign. And it is going to compress the endocyst and there's a rupture into the ectocyst, it's going to be called water lily sign. So, in clinical practice as well as in exam, the important thing that they ask is whether the cyst is active or not. So, active, we are going to give treatment. Inactive, we are not going to do anything much actually. Active cyst are type 1 and type 2 cyst, in which it will be a simple cyst or it can be a honeycomb kind of an appearance. Right from the presence of membranes to snowstorm kind of appearance to complete calcification, everything comes under either inactive cyst or transitional cyst. This is again the ultrasound CT correlation of WHO classification of cyst. Active cyst are these two, where it looks like this: simple cyst or septations. Transitional, in which it is like degenerating or partly alive, in which we will be able to see membranes, which was what we saw in our case actually. And multiple daughter cyst. Inactive was the other cyst we saw in our patient, in which there was a complete calcification. Coming to what is the IR treatment in it, yeah, surgery can be done, but more easier or more elegant way of doing is PAR. What is PAR? It is puncture, aspiration, injection, and re-aspiration. So once we aspirate everything, we are going to inject. What are we going to do? We are going to inject scolicidal agents. What are scolicidal? Either it is absolute alcohol or a hypertonic saline. For IR people, where do you go searching for absolute alcohol? You ask your pathology department or microbiology department. They are the only ones who will have 99% or absolute alcohol, which is medical grade, which can be injected into the liver. So yeah, check with your microbiology department if you're planning to inject absolute alcohol. How much should I inject? 1/3 of cyst volume. Calculate the cyst volume, aspirate everything out. Only 1/3 of the cyst volume needs to be injected, and you need to wait for 5 minutes before you re-aspirate it. One of the things about alcohol is you can't inject more than 100 to 200 ml, because in case it ruptures and it goes into the blood vessel, there will be acute toxicity of alcohol. So these are things that they might ask in exam about, and hepatic hydrated like PAR and what are the scolicidal agents which are used. Coming to the summary of the third case, it was a case of ruptured pulmonary hydatid cyst with hepatic and splenic hydatid cyst. So basically a multi-system hydatid cyst with ruptured pulmonary hydatid cyst. Take home message in it. Yeah, one of the important things is the pulmonary hydatid cysts do not calcify. And but the reason which is usually told is that there is constant movement because of which it becomes very difficult. So that is what my HOD taught me. John, lung, it keeps on moving. So because of that, it is very difficult for calcium to get deposited. But we need to remember actually the liver, which is closely associated to it, can also be on complete movement. So that might be one of the explanations, but really we really do not know what exactly is happening or why there is no calcification. But it will do us some good to remember there are like three areas in the body, namely the pulmonary and cerebral hydatids, which in which calcification will be absent or rare, and in bone it will be totally absent. So hydatids, the hallmark is going to be presence of calcification and membranes. This is how we are going to diagnose hydatids. But three systems in which calcification will not be seen in pulmonary hydatid is going to be bone, pulmonary, and cerebral. This one more MCQ. This is for PG students again. So the so all the hydatids are going to be spherical in shape. Whereas the bone hydratid is not going to be spherical. It is going to grow across the Havasian canals or the tubular. It's going to be more tubular and irregular in shape. So these are two questions which will be asked for PG students, like pulmonary hydatid, do they calcify or not, and what will be the shape of bone hydratids. So hydrogen is another important cause of cystic lung lesion, and whenever you see an lesion in a simple cyst kind of looking thing in ultrasound, do go back and do an ultrasound. So because like that is an active stage in which the patient will require treatment. So we saw the various signs, the three signs and the six signs of complete and incomplete rupture. Membrane is the hallmark. Why I wanted to portray this case was because the fat-containing cyst. Fat-containing lesion in liver is going to be very easy. Angiomyolipoma, HCC. These are the two things. What about a cyst which contains fat, and what is the explanation of a hydrated? If we see the reason why a hydrated cyst contains fat, it is because of two things. Either it means that there is a communication with the bile system in which the bile and the presence of fat in the bile is going to show the fat within the cyst. The second important cause is going to be the degenerating membranes, which is shown as fat. So these are the two important reasons why we see fat in hydrated cyst. There are enough number of articles in which this has been described earlier. So it will do us some good to remember that cyst with fat, one of the differential diagnosis is going to be fat, especially in a non-endemic area like in our place. In North India, it's very common to see hydrated cyst in your day-to-day practice. Coming to the last case was a 47-year-old lady with acute onset dyspnea. This was nothing really challenging about the diagnosis because this was a simple case of acute pulmonary embolism. What was challenging is what interventional radiological treatment that we gave in this patient. So earlier, whenever a patient had a massive pulmonary embolism, embolectomy, thromboembolectomy, thromboendarterectomy used to be done. These were usually done in the chronic phase, not in the acute phase. And over a period of time, IR has leaps and bounds measures taken to treat acute passive pulmonary embolism. Let's see what exactly we did in this patient. So basically, this patient had a massive pulmonary embolism in the main pulmonary artery, right and left pulmonary artery. So basically, I'm passing a wire into the right pulmonary artery. See, this is the IVC, this is the right ventricle pulmonary outflow tract, main pulmonary artery, and this is the right pulmonary artery. So such a curvilinear kind of an appearance. Then, so this is a right pulmonary artery angiogram. You can see this filling defect which is seen here actually. This is a filling defect we are able to see. This is a filling defect which we are able to see in the descending pulmonary artery. Can you see the filling defect which is seen here? These are the normal branches. So once we saw this, we started aspirating the clot. You can see the catheter which is moving and it is removing the clot. This is how much clot we got. So these were the clots which were aspirated from the right, left pulmonary artery, main pulmonary artery. So around like 10 to 20 ml of clot was aspirated. The important thing is it might sound very easy, like you keep a catheter, aspirate the clot out. So when there is blood as well as clot, solid and liquid thing, it is easier for the catheter to suck out the fluid out of it. So what actually happens is each and every time you aspirate, there will be more amount of blood which will be coming for the small amount of clot which comes. So in this technique in which I used an 8 French catheter, large wide bore catheter which was braided, we were able to get more amount of clots which was seen. So on table, this was a patient who came with, this was a 25-year-old lady with the LSCS recent history. So we couldn't IV thrombolyze her. Patient came with NORAD support of 20. And by the end of the procedure, once I aspirated all this clots, the NORAD requirement came from 20 to 3. That is the beauty of IR actually. The results are seen instantly, and this is even without thrombolysis. We couldn't thrombolyze because there's a history of major surgery. So overview of what we do in IR for pulmonary embolism, right from 1990s, catheter-directed thrombolysis started. Instead of giving a full dose of thrombolysis, what was earlier done was give half a dose or one third of the dose into the main pulmonary artery or right pulmonary artery. From 2021, we had more efficient catheters which were sucking more amount of clots rather than blood from the pulmonary artery. So this is a CDT method in which we keep these various kinds of catheter. We start infusing, it's usually a 5 French or a 7 French max catheter. And again, this is basically a thrombolysis, but it is a localized thrombolysis exactly in where the clot is present, so that the systemic complications are going to be less. Second method is going to be aspiration method, which is the more recent method in which we use either the penumbra, inari, or angiodynamics, in which these catheters are taken. So important thing is most of the time these catheters won't be available in our cath lab. So you have to have what is there with you. For example, in our cath lab, it was we had a catheter which was 8 French long, large bore, wide catheter. It was braided and at a very soft tip. So these are the requirements for any aspiration catheter because they have to go suck, they have to remove it out. So use anything which is 8 French or more for suction. If you have penumbra, well and good. Otherwise, just do a manual aspiration. It's equally better, or in fact, it is more better. At least you'll know when to stop aspirating and pull it out once you get that resistance. So either use a penumbra or indigo system. And yeah, there are recent devices in which you can aspirate even from the heart. Usually we don't touch the heart because we know once we keep poking, it's going to go into the main pulmonary artery. But there are recent devices, which is the angiodynamics, in which you can directly aspirate a clot from the heart actually. So important things is, yeah, we did a percutaneous suction thrombectomy or embolectomy in this patient, which had dramatic results. And yeah, that was the IR part of the treatment. And we need to know what is massive and submassive pulmonary embolism. This is basically a pulmonary embolism in which there is a hemodynamic instability. If, for example, there is a hemodynamic compromise of high systemic hypertension, it's going to be massive. Submassive is there is no hypertension, but there is right heart strain. What are the features of right heart dysfunction or myocardial necrosis? Is RV-LV ratio of 0.9 at echo and CTPA. So in CT, if we see the right ventricle is more than the left ventricle diameter, then it means this patient is having a submassive pulmonary embolism, or at least the patient is having a right ventricular dysfunction. So BNP, troponin T levels, all these things which will be seen in MI will also be seen in patients with pulmonary embolism. So this is a take-home message. So we have to familiarize ourselves with massive submassive pulmonary embolism and how it looks in CTPA with respect to the right heart failure and the tricuspid regurgitation. And we have to consider a possibility of embolectomy only in patients with massive and submassive pulmonary, not in all patients who are hemodynamically unstable, who genuinely require these things will definitely benefit from aspiration of clots. So my sincere thanks to Dr. Palniappan sir, Dr. Bali Babu sir, and Dr. Hari Krishnan sir for sharing with me the respiratory cases, which were tracheobronchial amyloidosis, Wegener's granulomatous, multi-system Hydatid with rupture lung hydatitis, and the pulmonary embolism case in which Karipia sir had asked me to glove up for a percutaneous embolectomy, massive pulmonary embolism. And thank you, sir. So these were the four cases which I presented in the Madurai Respiratory Society. Thanks for the invitation again to Palniappan sir for inviting me in this particular thing, and also Vivekanandan sir. Thanks a lot.